My name is David Johnson. I'm a brain and spinal neurosurgeon with a special interest in managing spine-related pain. I also run the Back Pain and Functional Movement Training Centre, which is a specialised service for back pain patients. The research shows us, and our clinical experience shows us, that back pain is a huge problem in our society. It's a huge problem in the modern industrialised world. There are discrepancies with less back pain in non-industrialised parts of the world, and there's good reasons to explain that. But in our society, our own burden of disease papers, the Lancet studies on back pain, World Health Organization, they're indisputably highlighting how back pain is a leading cause of disability on the planet. And I would say that in Australia, our Bureau of Statistics data would point to about 3 to 4 million people suffering from some version of back pain today, whether it be an acute episode or a relapsing remitting episode, which generally will progress to chronicity. So as a specialist with a major interest in back pain, I could be in my consulting rooms from 7 o'clock in the morning to midnight seeing people with back pain. It is the most prevalent reason for patients to visit me, and of course it's reflected by an extremely high number of presentations to the general practitioner. And I think the reason for this is that as a industry standard, there are so many variations on how the industry approaches back pain. I like to have my patients understand a very important factor, and that is that if you are going to be successful with your treatment intervention, you must address the cause of the pain. And a huge part of the industry really focuses on addressing the symptoms of the pain and really ignores the cause. And until we start to change our mindset and our framework of understanding back pain, I think the statistics and the data will continue to worsen over time rather than improve. And that is despite the fact that rehabilitation services for back pain are widely available to the community. So when I first meet a patient with a back pain, and usually it's chronic back pain because invariably patients will not be referred to me as a neurosurgeon as the first port of call. Most of the time patients will end up in my consulting rooms after months or years of back pain. So they will sit down and tell me the usual stories that they've had countless sessions of strengthening, stretching, massage, manual therapy. They've had exercise physiology. They're on numerous medications. On average, 3 different types of painkillers are being consumed or at least have been tried. And they are continuing to worsen over time as opposed to improve. So I have to take on these patients who have quite significantly different backgrounds, but synthesize that down to a very fundamentally clear origin of their pain. I explain to patients that the holy grail of managing their pain is for them to achieve stability around their lumbar spine. Stability is comprised of 3 main factors. There's the active factors, there are the passive factors, and there's the neural control. What I mean by active factors is I mean the muscular activity that surrounds a joint. What I mean by the passive factors is the spinal integrity, so the non-contractile elements that make up the spinal integrity, which is the facet joint capsule, the tendons, the ligaments, the cartilage. And when I refer to the neural control, I'm referring to how the brain and spinal cord control the movement of the joint. Now, as a specialist, I will very often, almost invariably, have imaging to assess the passive and the active structures of the spine. And the vast majority of patients, probably 99% of patients that I see with back pain, do not need any intervention on the structural integrity of their spine. They do not need to become stronger, because if you actually think about it, they're an accountant, they're a teacher, they're not engaged in high physical demand activity. So the only factor that we can really optimise for those patients is to enhance the neural control of their movement. And that means we have to make them more skillful. And a lot of the rehabilitation methods that are existing for those patients do not enhance the skill. So as a specialist, my recommendation is for those patients to focus on a rehabilitation methodology that improves their functional movement. Reactivate comes into this equation in a very, very specific way. It has the power to synergistically help and optimise a rehabilitation methodology that specifically focuses on enhancing that neural control. Because the other elements of stability, structure and muscle activation, are not deficient in those patients. And the risks associated with structural intervention surgery far outweigh the benefits. And Reactivate can achieve those goals very effectively with a minimally invasive, almost pinhole approach, and performed in a day surgery setting, which is why I'm very passionate and excited about utilising the technology of the mainstay Reactivate system in my patients and in my clinical practice. So assessment of any patient surrounds three major tenets of medicine, which is history, examination and investigations, and in that hierarchical order. The history is very important. They have to be a patient that describes significant pain and disability associated with their condition. No patient wants to undergo a medical procedure without first assessing the risks and benefit of the procedure. Patients who are candidates for Reactivate obviously have back pain and disability that is interfering with their quality of life. They have often tried numerous interventions that have been unsuccessful. The next assessment phase is to examine the patient, of course. We need to exclude red flags, we need to exclude spinal cord compression, we need to exclude neural impingement, because if those factors are present, it's a very different paradigm of treatment. You follow a different algorithm for that. When we've excluded red flags, we need to see some evidence of instability, and there are clinical examination elements that help us identify instability of the lumbar spine. And then we go to the imaging, which then further supports a lack of neural compression, and also supports our provisional diagnosis of instability related very much to multifidus muscle atrophy. And the multifidus is an extremely important muscle, and it's quite understated in its importance in relation to lumbar spine stability. So the multifidus muscle is a very unique muscle, and it's unique in the sense that it is considered to be one of the only intersegmental stabilisers of the lumbar spine in relation to back pain. The multifidus muscle does extend up the whole spine, but in relation to back pain, if we lose the ability to control and contract multifidus correctly, we can develop a condition called micro-instability. And that means that when we go about our normal everyday activities, we are engaging in those activities with micro-instability. And what does micro-instability mean? That means that over time, the accumulative build-up of biomechanical stress transfers into biological inflammation and nociception. Unchecked biological inflammation will ultimately result in structural changes to the spine. And if those structural changes to the spine continue, that's when you have to step in as a surgeon and perform quite invasive structural intervention surgery. We want to get people before they have the consequences of that unchecked biomechanical stress. And if we can restore the function of multifidus, which allows us to stand up and bend and prevent microinstability, then we will be able to successfully prevent the progressive deterioration of the joint and consequential pain and disability that the patient experiences. There's numerous assessments of the impact that back pain has on our society, and universally it is one of the leading causes of disability and pain in the country, and going hand in hand with that is a huge economic burden. Back pain patients, they consume an inordinate amount of health dollars and they cannot contribute back to society. So in that regard, back pain is in the first or second ranking of conditions that our health system must address effectively. Back pain has a huge impact on the quality of life of people. One of the ways that people manage back pain, in addition to the medical input, is that they severely and progressively restrict their quality of life. And I call that Oprah therapy. You can manage anything by sitting on the couch and watching Oprah. But in terms of your quality of life, if that's the approach that you take to managing your pain, you are on a very, very steep, slippery slope to further and further restrictions that ultimately end up in a very poor quality of life. So the fact that we can arrest that cycle or that patient going down the slippery slope is transformative for their lifestyle. They can return to playing with their children. They can return to having healthy, enriching relationships. They can return to gainful employment, and as such can start contributing to society again and eliminating that massive clinical and economic health burden on our country. Regardless of age, a 20-year-old can experience pain just as badly as a 65-year-old. And the common factor is, does that individual maintain stability in their lumbar spine? So for an elderly patient, it's just as important that they maintain these attributes for their spine health as a younger person. How has Reactivate changed my practice? In years gone by, when I saw patients with all of these features of dysfunctional movement, multifidus atrophy, they were in the category that would not have benefits outweighing risks of major spinal structural surgery such as fusion or disc replacement. My recommendation at that time was to engage in a very specific type of rehabilitation, which I referred to as functional movement therapy, which is a therapy that enhances their biomechanics for movement in everyday life activities, hence allowing them a foundation to then build capacity upon, which then allows them to regain those quality of life attributes. However, what became clear was that there are still a lot of patients who have multifidus atrophy, and that although they would improve with the rehabilitation, they would still be describing the pain that was associated with their micro instability. Because regardless of how good the rehabilitation is, if the nervous system is not able to effectively activate the multifidus muscle, you cannot gain the level of stability that's required to eliminate that pain and disability. So there's a phenomenon referred to as synergistic dominance, and I can make someone bend and squat and hinge to a high level of proficiency, but they may be engaging in those movements with the wrong musculature. And if I don't have a means of specifically isolating the multifidus activation, they will continue to do those movements with the microinstability unchecked, and hence the limited outcomes that may arise in people who we don't capture early enough. Direct multifidus stimulation is a way of getting around that problem of synergistic dominance, because we don't want the muscles that are not required getting stronger and allowing the muscle that is required to get weaker. Otherwise, we are still in the same situation of microinstability of the lumbar motion segments. I think one of my main take-home messages in regards to back pain is that, number one, recognising that it's a major problem, not just in Australia but worldwide. Recognising that as an industry we can and must do better. We have to recognise a very precise, robust clinical model for back pain, which is cause-based. And once we accept that, and once we accept accountability for our outcomes, we can then start to implement a cause-based solution. And I am extremely excited for the future with the utility of the first functional surgery that Mainstay and Reactivate provide to my practice.